a medical dictionary, the first thing you'll get is its identification of a disease. Notice a disease, that's a really important point here, or condition. And it's by scientific evaluation of physical signs, symptoms, history, laboratory test results, and procedures. Scientific and physical evidence. Immediately we're slightly in a difficult position in psychology, because the majority of things that happen in psychology happen inside the black box that is between your two ears, and it's very, very difficult to extract physical information about it. It is true, for example, that serotonin is implicated in depression, that dysfunctional reuptake of serotonin, which is why SSRIs work for some people. You with me with SSRIs? Yes, antidepressants? However, it's only true for a subgroup. There are people who are depressed who have all the symptoms and all the signs, and their serotonin is absolutely normal. And there are also people who have dysfunctional serotonin, and it doesn't express itself in depression. So there is no complete overlap between what happens physiologically and what happens psychologically and behaviorally, which is a problem for us. With diagnosis, there are also two other things that you need to remember. One of them, that while diagnosis itself is a labeling procedure, it's saying you have this particular label, and it's based on signs, symptoms, case history, and laboratory findings. Differential diagnosis, you'll hear doctors saying, I'm going to carry out a differential diagnosis here. That's an attempt to say it's this and it's not that. In other words, there's several suspects, and I'm going to take everything, all the information I have, and try and say which of the several suspects it's most likely to be. And again, that's very difficult for us as psychologists. But now that we've got a definition of diagnosis, we need a definition of mental disorders. And I've taken mine from the American Psychiatric Association, which is the most influential association to deal with all of this. And this is what they have to say. We already said what we had to say. And we weren't that clear about it, yeah? But they say significant behavioral or psychological syndrome patterns, so it's a group of things for starters. It occurs in a person, and it's associated with distress, disability, significant increased risk. We talked a little bit about self-harm, but there's other types of risk, yeah? To do with impairment, with disability, and so on. And that's a very medical approach. Next week, it's all about the medical model and diagnosis. The lecture next week is given by Daniela Serbic, and she'll also give the one after that. And hopefully it will clarify this way of thinking about things. But I wanted to throw a spanner in the works, if that's the terminology, and to show you that not everybody agrees even with the idea that we need to diagnose. We thought that maybe we do need to diagnose. Why? We wanted to know more about ourselves. We wanted to put a little bit of distance between us and people who we perceived as threatening. What other advantages are there to diagnosing people before we go into this? Yeah. In order for them to get treatment, most people think intuitively that you need a diagnosis in order to get treatment. That is absolutely true. Anybody want to challenge that? Yeah.
If you know the problem, you can challenge it from, and you can solve it. If you don't know what the problem is, you are still in this great area that makes sense, and it's confusing.
It can be confusing. Yeah.
Diagnosing, you can have it, can go in a record, so you can get disabilities for work.
Very good. You know what? Nobody ever in the whole history of me giving these lectures has thought of the practical implications of getting a diagnosis. Yeah? Anything else? Yeah?
We said earlier that some people aren't diagnosed necessarily as a mental disorder, but they still need treatment, so it's not necessarily useful.
Yes, we did, didn't we? And we all agreed about that, that people can benefit from psychological treatment without a diagnosis. Yeah? Yeah, I think that's a really important one. However, I do want to stress that it depends on the diagnosis. We have some diagnoses which are different to others. So, for example, there's a big, big difference between diagnosed with depression and diagnosed with schizophrenia. And if you're diagnosed with psychosis, ongoing psychosis, it's got some practical, again, going back to your point, some practical implications. If you have been sectioned, you know what sectioned means? Is anybody who doesn't understand the term sectioned? Quite a few, okay. Section is when you are taken into care for your own good. Again, we talk about this in the very last lecture. When you, in effect, sometimes because you've asked for it, but more often because your family have asked for it, you are removed and incarcerated, for want of another word, in order to be observed and treated away from society. That's sectioned. One of the implications of being sectioned is that many patients lose their driving license. It's considered unsafe for them to drive, and it will take them 6 months before they are assessed again and allowed to drive again. So in those cases, having a diagnosis and having a label has got a profound implication on your life, and it's not a particularly good one. In terms of uncertainty for family, I totally agree that if you've had somebody behaving very, very weirdly and disruptively within the family, and finally somebody comes and says, oh, but you can expect this because this is bipolar and this is what's going to happen and you can do this, and it helps manage, it brings it more peace of mind, depending on the diagnosis, always. I work in pain. This is my area of expertise, which is not a mental disorder, but a lot of people in pain develop severe depression, they become very disabled, while as other people just sail on and they're absolutely fine. It's also very, very common. About 80% of you at some point in your life are going to have low back pain to the extent that you won't be able to work. You won't be able to move around the house regularly. So this is really common. It's got huge cost implications. And one type of pain that I deal with is called fibromyalgia. Have you come across fibromyalgia? Hands up those of you who know what fibromyalgia is. No, one, okay. Fibromyalgia is pain in lots of areas of the body. You get very, very tired. It can be aching, it can be very, very painful, very often associated with depression, and nobody has concrete evidence on whether depression causes fibromyalgia or having fibromyalgia makes you develop depression. There is no cure for fibromyalgia. There is no treatment known to work universally for fibromyalgia. So if you've been visiting your GP for 2 years, coming back and back and back and saying, but I am hurting, and your GP has turned around 1,000,000 times and said, but I can't find anything wrong with you. There is no lesion, there is no problem. And finally, they come out and they say, fibromyalgia. Evidence suggests in the first week, people go, yes, I have a diagnosis. At last, somebody's found what's wrong with me. And then when they start researching what fibromyalgia means and what the prognosis is and so on, they dip again absolutely down to deep depression. Oh, great. So I have a disorder that nobody knows what causes it, totally differs between people, and nobody can cure it. Great. But we have come across some reasons why we would want to diagnose. There has been some challenges here, and I agree with those challenges, about whether you can treat effectively without a diagnosis. Now, the majority of psychological treatments are based on a few principles. The approaches that we show, that we've talked about already. Say cognitive approaches. Say you think that somebody believes things that are wrong, thinks about the world in a wrong way, etc. What do you think will be really strong predictors of whether psychological treatment works or doesn't work? Just off the top of your head, when will it work and when will it not work? Yeah.
When the patient is cooperating.
Cooperation from the patient. What will cooperation from the patient depend on? Yeah.
But if the patient's not willing to get better, they don't want to accept that they have a problem, they're not going to make the effort.
Okay, so if you don't want to get better, nobody can work with you, yeah? Yeah, which is true for most personality disorders. I teach you next year on personality disorders. The majority of people don't want to change, are not aware of a problem. But the point I'm really trying to get at, how do you get a patient to come on board and say, I want to change? I do recognize now that I have a problem and I want to change. How do you think you influence? You're all psychologists to a certain extent. You're here. What would you do naturally? Yes?
If you show them the benefits of what will happen if they do change, like what factors of their life are going to get affected by it in a positive light, then we're likely to change.
Give them information. Information doesn't affect us that much. Yeah.
So it affects their personality or behaviours having on people they care about.
Guilt. Let's work on guilt. Look what you've done. Look at your mother, you. Okay, what do you think? Will they come back? Next. What do we do when we feel guilty? Especially if it's right. You said you were going to phone me and you didn't phone me. I sat there by the phone the whole day. I could have gone out. Do you realize how let down I was? What kind of a friend are you? Your emotional response? A bit of guilt, and then? Resentment. Resentment. That's what we do as human beings when we are made to feel guilty. We don't take it on board. We don't go, I feel guilty and therefore I'm going to be nicer to you. We go, this is very unpleasant. I don't want to be exposed to it, so I'm just going to take a step back. See you in a couple of weeks when this is blown over. That's what we do. Or we fight back sometimes. Oh, but you did that to me. Great. Guilt is not going to get our patients to buy in. What's going to get our patients to buy in?
Like if you show them like real-life examples.
Real-life examples, we're back to information. Here's smoking, here's lungs, you smell like an ashtray. Have we stopped? No, we haven't. What? Yes?
Help them for today, for the moment, because it makes it easier to take things little by little as opposed to looking. If you like overwhelm them with like just the benefits or whatever, in the distant future, it doesn't feel important. But then if you give them something little that will help them for today, it's more likely that they're going to work on it.
I buy that. That's a here and now technique. Keep it small. Yes, at the top.
Sometimes you have to let them hit rock bottom to understand sometimes.
Smoke 5 packs of cigarettes, then you'll want to stop. Yeah?
Maybe sometimes you just have to find the particular person's weakness and somehow use it against them.
Oh my gosh. Okay, guys, as psychologists, as friends, let's take it a step back. Okay, you have a friend who is unhappy and you want to help them. What's the first thing you do? Yes.
Discuss with them and
Let them talk, yes. Empathize, thank you. Yes, show empathy, create rapport. We are talking about a professional alliance, a patient-practitioner alliance. Without that alliance, without trust, rapport, there is no cooperation, there is no buy-in. My relationship with my patients will predict whether they get better or not.